My name is Ayhan John, and I'm the president of the Southeast chapter of SCCM. We will go ahead and get started. And before we start a lecture, I'll make a brief announcement from the chapter. The first slide has the QR code for the CE credit for today's talk. The CE credits are due in 2 weeks from the talk. So please scan the QR code and complete them before the deadline. This QR code will also be available on the last slide of my announcement. And we start every meeting by stating the mission and vision of the chapter. The mission of the chapter is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. The vision is that all critically ill and injured persons in the Southeast chapter or region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. In October, the chapter raised awareness for sepsis through a 5K run, which was held in partnership with Karen Thicken, who was a local sepsis survivor. These are photos from the event, and we had a successful turnout and raised over $3,000 to benefit the Sepsis Alliance. If you're interested in learning more about the event or volunteering for next year's event, please email us at communications@sccmse.org. Stay tuned for some of our upcoming events. On December 11th, we'll be holding our chapter's annual business meeting. Please call in to learn more about our achievements during 2024 and also some of our events planned for 2025. This is an invitation-only event for our chapter members, so please register ahead of time. An email has been sent out, and we'll send another email reminder closer to the date. Also, if you're planning on attending the 2025 SCCM National Congress, please join us for a networking event. This event will be held at Hyatt Room Challenger 39 on February 23rd at 4:30 p.m. This is open to all SCCM members, specifically Southeast chapter members. And please register, if possible, ahead of time so that we can get a head count of members attending. We'll also be sending a separate email advertisement on this as well. Lastly, if you have not already, please follow us on social media for any updates. You can also email us at communications@sccmse.org for any suggestions or questions. Now, it is my pleasure to introduce the speakers for our talk today. We're honored to have two distinguished speakers join us to talk about the guideline updates on rapid sequence intubation. Our first speaker is Dr. Whitson. Dr. Whitson grew up in Alabama, graduated from Auburn University, then earned his medical degree in 2007 at the University of South Alabama. Dr. Whitson matched with a combined emergency medicine and internal medicine residency program at Hofstra University Northwell Health in Queens, New York, followed by critical care medicine fellowship at the same institution. Dr. Whitson is appointed as an associate professor of medicine at the University of Alabama at Birmingham and is honored to lead large multi-center pragmatic randomized controlled trials in the realm of critical care, specifically focusing on airway management as the site PI for UAB's emergency department and intensive care units. As Associate Program Director of UAB's Critical Care Medicine Fellowship, he also functions as a mentor for residents pursuing critical care fellowships and provides critical care education for faculty, residents, and students. Clinically, Dr. Whitson is the Director of Critical Care Ultrasound for the Division of Pulmonary Allergy and Critical Care Medicine at UAB, and he works as an intensivist in UAB's medical units, as well as in emergency departments. Our second speaker is Dr. Pantawala. Dr. Pantawala is the chair of critical care pharmacy, jointly based between the Sydney Pharmacy School and the Royal Prince Alfred Hospital in Australia. He is clinician and researcher and critical care pharmacist at the Royal Prince Alfred Hospital. He completed his Doctor of Pharmacy, General Residency, Critical Care Specialized Residency, and subsequently a Master of Public Health in Biostatics in the US. He has over 2,000 publications, including in the Journal of New England Journal of Medicine and JAMA, and received over $4 million in competitive grants as a chief investigator. He serves as a deputy chair of the Clinical Trials Subcommittee for the Sydney Local Health District and is a member of the Medication Safety Expert Advisory Committee for the Clinical Excellence Commission in Australia. So please welcome our speakers. And throughout the lecture, please utilize the chat box on GoToWebinar to pose any questions, and we'll have a Q&A session at the end. Now I'll hand it over to our first speaker, Dr. Whitson.
I believe I'm unmuted. I'm going to shift this over here and presumably share the screen. There. All right. Hopefully everybody can see okay there. Yeah. All right. I'm getting nods of assent. So thank you guys for inviting me here. I appreciate it. Clearly from the introductions, you can tell that I am the least productive and least important part of this talk. And so I am going to fly pretty quickly through some of the clinical stuff associated with RSI and airway management. Let's see, the goals and learning objectives is first I'm going to provide an overall review of what RSI entails, and we also want to, the title of the talk is reviewing and emphasizing the SCCM guidelines for the performance of this procedure. And I think some of the important stuff, is supposed to be educational, reviewing some of the supporting literature, not in grave detail, but in general thoughts for the decisions, that the SCCM guidelines reached. All right. There will be a little bit of literature and publications that we've been involved in that may have occurred after these guidelines were written, and I'll review that a little bit as well. So the first thing about RSI, and of course, if anybody has any questions at any point, I've got the chat box pulled up over here, right? So hopefully this won't be too dry. But I think we can fly through the first parts and get to the meat of the matter. And again, the real meat is the star presenter coming after me. So our indications for intubation generally are going to be respiratory failure of some sort, neurologic failure of some sort, what the vaunted failure to protect an airway. And then there's the ever vague clinical gestalt for impending deterioration. We won't dig into a whole ton because of its complexities. The actual performance of this procedure is it begins with preparation for the procedure after you've identified that it needs to be done, right? I like to divide the preparation into the sort of equipment and meds that you will need in order to accomplish the procedure, making sure that the equipment is functioning and the medications are accessible. And then an assessment of the patient, which is the patient's risk pre-procedure and the appropriate monitoring associated with the anticipated risk, and then the plan that you will use for the procedure itself. There is a lot more than just stick the tube in the hole. There is the overall general approach, the roles of the team. You have to have a team-based approach because no man is island. You can't do it all by yourself. And you also have to have what your backup plans are should your initial plan meet without success. Then we get to the actual procedure in and of itself, where we're beginning with pre-oxygenation, where we try to increase the underlying physiologic reserve, what we'll sort of measure with the effective apnea time available before critical hypoxemia. And there's pre-oxygenation occurs both pre-induction of anesthesia with medications and then post-induction of anesthesia with medications up until the time where a tube is secured and mechanical ventilation is able to begin, or bag ventilation, and so the procedure, once you complete or begin pre-oxygenation generally occurs throughout the procedure. You're going to use meds, and that's where Sid is going to be able to present lots of data and information. Most folks doing RSI are using usually a sedative and a paralytic. There's a lot of detail to cover there. We'll get to it. And then the intubation itself, right? After you've pre-oxygenated, you're taking it down, and then you have to, number one, visualize the airway. You have to see where the tube's going. Then you have to be able to get the tube into the place that it needs to go. Then you have to be able to confirm that the tube is actually in the airway successfully. And then very, very briefly at the end, we'll talk about just the ventilator and sedation, right? Because, you know, just having a tube in the hole is not enough, right? We have to be able to provide oxygen and ventilation to patients afterward and do it in a semi-comfortable fashion. That's going to be very brief. So we talked about the RSI indications. You've got respiratory failure, hypoxemia, hypercapnia, or just general work of breathing, which is frequently associated with severe acidosis. There's the neurologic failure I talked about. Again, airway for quote airway protection, that'd be severe stroke, severe encephalopathy, NOS, and then this impending deterioration, which we won't talk about a whole lot. We're not going to go deeply into the details of this because it's not really a part of the guidelines, but just to provide a background of why we're doing this thing, right? Some of this is in the guidelines, right, for the overall.
Sorry, Dr. Whitson. So sorry to interrupt. I think your screen might be stuck because we're still seeing the title screen.
Oh my. Well, I see that. Oh, it says that it's paused for some reason. We're on pause. Okay. So,
Thank you. I see it now.
Okay. Good. So just to, oh boy, I could see that maybe you guys were, thank you for interrupting there. I wasn't monitoring that other side closely enough. All right, so very briefly, because I already said the words, goals and objectives. It's the things that we're going to do that I talked about. The indications, the preparation, and the procedure, the things that I talked about, right? And then that catches us up, right? We talked about the indications themselves, the various respiratory and or neurologic failures, and then again, that gestalt for they're going to get worse and going to need it anyway. Let's go ahead and do it now while we have control. All right, that catches us up, and I apologize for the inconvenience there. So the preparation, right? You've got your equipments and your meds. They need to be around and available, right? This includes your oxygen delivery mechanisms, your laryngoscope that you're going to use in order to visualize the airway, any intubating aids or assistive devices you might want to use, and then of course the rescue maneuvers that you would go through or rescue needs you would need should your first attempts fail. Then we talk about in preparation assessing patients' risk and appropriate monitoring for it. So patients can be either anatomically difficult airways or physiologically difficult airways, or a combination of the two, right? Anatomically difficult means that their airway is different, that they are at high risk for aspiration, or that they have, for instance, maybe a mass in the oropharynx from head and neck cancer. That'd be one example. There are also things like micrognathia and poor airway opening with trismus or whatever. We could name any number of anatomical challenges which could make a patient more high risk. And then you've got physiologically difficult airways. The most commonly encountered physiological difficulties are going to be those with very tenuous hemodynamics, right? Because as said, it's probably going to touch on some of the medications, and not some, most sedative medications play some role in hemodynamics, right? Predominantly worsening them, causing vasodilatation, and then hypoxemia, right? Intubating a patient who does not have much of an AA gradient, a patient who has a PaO2 of 5,000, who, that's obviously an exaggeration, but who has all of the apnea time in the world, is going to be much, much easier and less risky than someone who on the maximal oxygenation you can provide them is so hypoxemic that they're physically cyanotic and in distress in front of you, right? And so we'll talk about that a little bit because some of that weighs in with what we're doing, according to the guidelines. And then the plan has to do with the general approach and roles, right? Role assignments for the teams and your backup plans, the order of operations of who's pushing what when, what you're going with, which tube, when, where, and how, okay? So the equipment and meds, right? You've got various options for oxygen delivery that I'm not going to belabor here because we're going to get into them. You've got your laryngoscope itself, either direct versus a video, which we'll talk about very briefly because there's some new data on that probably just confirms what most people already suspected. The most common intubating aid that people tend to use, at least here in the United States, can't speak greatly to what's done in Australia or other countries, is going to be the gum elastic bougie, and some people use it exclusively, others use it sometimes or only when needed or as a rescue. And then your other, like, more clearly rescue devices would be LMA placements, intubating LMAs, fiber optic scopes, potentially even a King airway. That's very commonly used in the US and outside hospital settings. And of course, the surgical airway. So regardless of what the risk of the patient is, being prepared and knowing your equipment, knowing where it is, and by risk, I mean patient risk, and risk of initial failure is wise. So here we're in some SCCM guidelines, right? That's what you guys came here for. And this is in regards to anatomically difficult airways predominantly, all right? Although there is potentially some physiology associated with some of this. So the first one, the SCCM guideline, we're going with positioning, right? So the SCCM guideline suggests using an inclined 30, and I don't know if you guys can see me very well, but up to 30 degrees, 30 to 45 degrees incline position for the intubation of patients during RSI. I'm taller than the average bear, and so this also helps for my own personal ergonomics to make it more comfortable for me to intubate. We recognize that, they recognize that the evidentiary support of saying people should be intubated not laying flat, but instead with the torso inclined 30 to 45 degrees is very low. So as a brief overview, they quoted three, which I've looked through, they quoted three observational studies, one of which those had improved first pass success. I think that sort of makes sense because most people, when the bed is down, the airway is lined up, and if you raise it up to be in line with your eyes, you're more likely to be able to see and more likely to be able to put the tube in the right place. One of these studies showed that there was actually a reduction in arterial oxygen saturation, but again, these are observational studies, and any reductions in aspiration, which is a theoretical advantage because gravity pulls fluid down and makes it potentially less likely to go up the esophagus, is with observational studies potentially a bunch of noise. Another observational study showed no difference whatsoever between inclined and flat. And the one RCT that's sort of been done showed actually decreased first pass success, maybe a worsened view with increased laryngoscopy attempts and no other known benefits. However, the vast majority of those were done with direct laryngoscopy, and it was a small study with less than 100, with an N less than 100. And so what, in a single center, no less. So what exactly can you take from that? There have been multiple cadaveric simulation and OR studies. Again, these are not RSI, and these are not in the way that people usually do, which are almost all positive studies. And there are so many biases that you could sort of imply or see in these types of studies. So my overall gestalt in this guideline is to agree, mostly because we have no clear evidence of harm. The one RCT notwithstanding, which had, cannot necessarily be generalizable to what we would probably consider the usual practice where we are here. And if it's less, and there's no physiologic reason that this would harm patients. Number two, there is certainly physiologic arguments that could suggest benefit. And number three, ergonomically, it's just generally more comfortable than crouching down and trying to do something in a very small, tight space. So that's one guideline. They suggest everybody should be lifted up 30 to 45 degrees. All right. So second would be nasogastric tube decompression. This is an official guideline. The SCCM advises nasogastric tube decompression of patients when the benefit outweighs the risk for patients going for RSI, right? Especially if they're at high risk for regurgitation, aspiration, gastric continence. So this is just a best practice statement. It is all opinion, because there is no evidence. There are almost zero studies evaluating this specifically in any way, shape, form, or fashion. Now, there are plenty of studies that allow imaging to be able to let you know whether there is a full or distended stomach, whether you use, X-ray or more commonly, in my specialty, ultrasound. Or in patients who have known intestinal obstruction, where you see that they have big gastric contents on CT from an SBO, and they've already vomited and aspirated, causing respiratory failure. That's why you're intubating to begin with. And I think in those situations, that they would clearly be considered high risk. And my personal practice is, especially if we're going to put an NG tube down anyway, like, go ahead and do that first. Suck out what you can in there. And so in this situation, if the patient is high risk, it'll affect your plan. But of course, for the rest of the talk, we'll also have a little bit of touching base on whether the plan that you're using might impart risk to a patient, okay? So in that vein, we have our plan with the roles, approach, and rescue, right? We talked about order of operations, role assignments for the team, and your backup plan. And when you're planning, that planning begins with pre-oxygenation, because you have to plan how it is you're going to pre-oxygenate patients, right? So that allows us to segue into actually doing the procedure, which begins with pre-oxygenation. So again, I talked about how that's pre and post induction, and they may be different. And the procedure itself then will, touch on meds for sedation paralysis. And then intubation, we're going to fly through briefly, because the intubation, ventilator, sedation, because that's not really, guideline recommendations there. Okay. So the pre-oxygenation generally is in respect to the physiologically difficult airway. Okay. And the guidelines touch on this because it's a fairly big topic, right? I think Sid probably is going to touch mostly on hemodynamics, because the largest effect is in his area of expertise. But we will talk about pre-oxygenation specifically for patients who are hypoxemic here. And the SCCM guideline suggested pre-oxygenation with high flow nasal oxygen when laryngoscopy may be expected to be challenging, okay? They suggested pre-oxygenation with non-invasive positive pressure in patients with severe hypoxemia that involves the physiologically difficult airway, where there is a much lower physiologic reserve of oxygen for the patient due to their underlying illness. So at the time of these recommendations and guidelines, this was a conditional recommendation with, quote, low evidence, although there's a little bit of a more recently emerged evidence that's strong, provides stronger evidentiary support, okay? The evidence goes sort of as such, right? High flow oxygen versus face mask, because the standard of care for a pre-oxygenation for as many years as I can remember backward, which is admittedly not a whole ton of years, but especially in emergency medicine and critical care, it is place a non-rebreather face mask over a patient and let them breathe what they can to try to wash out nitrogen and get as much oxygen in as possible, and then just take that off and put in the tube once they're sedated, right? There is some very limited amount of evidence for this in comparison of high flow versus non-rebreather masks. An RCT that had pretty low numbers, it showed no significant difference. Another RCT where high flow actually reduced the likelihood of desaturation during the procedure in comparison to standard non-rebreather mask. Again, relatively low numbers of patients. Both those single centers. There were multiple retrospective and case series and prospective sort of before and after trials. Strength of evidence, again, commensurately not strong. There have also been various comparisons of high flow to non-invasive, mostly with inconsistent results. The one consistent result across all of the observational and prospective and randomized control trials with non-invasive positive pressure for pre-oxygenation is that it seems to be safe. No trial that's been found and been reviewed, and including multiple reports and series, showed increased risk. And that's the biggest fear, is that if you put someone on non-invasive positive pressure ventilation for pre-oxygenation purposes, you're going to pump up their belly because of the positive pressure, and you're going to make them vomit. Everyone who's intubated knows that vomiting during intubation when sedated and paralyzed is frequently catastrophic. And those of us who have had that experience never want to experience it ever again for ourselves or our patients. Enter new information that didn't exist when these guidelines were written, which is the pre-oxy trial. This is a much larger trial. It's multi-center across many centers throughout the United States, with multiple centers here in the Southeast. We were one of them. Vanderbilt's the leading center on this study, 1,300 patients. And this is comparing the standard of care non-rebreather mask versus intentionally pre-oxygenating, randomizing pre-oxygenating each of those patients with non-invasive positive pressure ventilation with clear reductions in significant hypoxemia and improving outcomes. Okay, so yeah, they're recommending this for severely hypoxemic patients, even without the extra now strong evidence that exists showing you get improved outcomes and reduce the likelihood of severe hypoxemia. All right, any questions about that? I'm glad to entertain. So we next in the SCCM guidelines, we'll talk about physiologically difficult patients, right? And then fly through the rest because it's the last of my guidelines, and that's in behavior. Right, so we frequently have patients who are overwhelmingly delirious, in part because they just can't breathe. And the suggestion from SCCM is to use medication-assisted pre-oxygenation to improve pre-oxygenation in patients who are going to be undergoing RSI, especially when they cannot tolerate face mask, non-invasive, or high-flow nasal oxygen because of their underlying illness. So this is a conditional recommendation because of not just low evidence, but very low evidence. And this is what we call DSI. It's frequently termed delayed sequence intubation, where most people will use ketamine, which generally spares the airway reflexes, allows patients to continue to breathe at a normal rate and keep their airways open themselves, while putting them in a dissociated, heavily sedated state where they can no longer intentionally fight back or rip a non-invasive positive pressure mask off of their face. And so they allow or are forced to allow appropriate pre-oxygenation to occur. I do this not routinely because most folks can be talked through this process, but certainly there are those who don't, and it is again, there's no great evidence for this. I 100% agree that this is a reasonable thing to try to do with tons of preparation beforehand, because it is just a whole lot safer and easier to take someone who has been dissociated and allowed pre-oxygenation with non-invasive positive pressure for 5 minutes and begin your actual intubation approach and apnea time with paralysis from a SAT of 100 with a presumed PaO2 in the several hundreds versus the person who had been ripping all oxygen off of their face and thrashing around cyanotic and beginning with sedation and paralysis from a SAT of 70. So again, the problem with doing studies on this is that it's almost impossible to randomize and ethically control for these and get good data out of it. All right, so now we're into medications. I am not going to actually do this. This is for Sid, and that slide is really terrifying. So we're going to move on, right? He has an entire talk with many slides associated with it, okay? And we'll fly through the last two parts, right? We no longer have a whole lot of guidelines to talk about, and that's what we're here for. So intubating, visualizing the airways, the first step. New information that didn't exist, when these guidelines were written, were the device trial, randomizing in very large numbers, again, video laryngoscopy versus direct laryngoscopy for emergently intubated trachea patients who were also almost exclusively undergoing RSI. Spoiler alert, VL gave people a lot better views, and it resulted in a lot better first pass success. We actually, semi-disappointingly, had to stop this trial way early for efficacy and the safety concerns associated with direct laryngoscopy, not being as good. So we talked then about tube placement itself, ET tube to stylet with stylet versus plain ET tube versus using a bougie first. That's also been studied, and there's no clear consensus or strong evidence favoring one over the other. And then confirmation of the tube is with direct visualization, as well as CO2 detectors, capnography, and then later on down the road, chest x-rays, plus or minus bronchoscopy if you have an indication for that within the airway. All right, after the procedure, we put people on the vent. As a general rule, for patients who have a lot of critical illness and sickness, we use lung protective ventilation, which has pretty strong evidence for it. We're not going to dive into. And then we also use sedation, because when patients are paralyzed, they should have sedation and pain medication. There are extensive guidelines on that, which were published by SCCM within the last handful of years. And the answer, as a general rule, is pain first, and oligosedation. Use as little as is necessary to make sure that the patient is well taken care of. Obviously, if there are deep questions about that, we can entertain those. So thank you for your time. My simple part's been finished, and we'll leave Sid the actual hard work of explaining every physiology and pharmacokinetic of every type of medication ever used, right?
Did you say all of physiology and pharmacokinetics?
All of physiology and all of pharmacokinetics for every sedative and paralytic medication ever. That is what you're covering, right?
All right. It's a tall order. Thank you, Micah. That was great. Great background. And let me see. Let me share my screen there. Just want to confirm that. Can you see my screen, and did it move?
Yes.
Is that a yes? All right.
Thank you for not making the same mistakes I made.
All right. Well, yeah. Thanks for having me. And so the second part is focused on medications, and probably what I'm more familiar with. And my goal here is, in a way, to give you a background, a behind the scenes view of what it was like being on the guidelines and on the panel, and some of the discussions behind the scenes, because you're probably wondering how we came up with some of these decisions, because a lot of this doesn't have a lot of evidence, and at least not a high quality of evidence. So I thought it was fascinating behind the scenes of how you finally go to making a recommendation. So I know that you can read the guidelines and there's a lot in there, but yeah, that's what I wanted to convey, is some of maybe discussions that we may have had that is not readily sort of apparent. So I don't have any conflicts of interest other than I am an author for articles that were used in a couple of the PICO questions for the guidelines, and I did let the panel know about this up front, and so everyone's aware. Yeah, so my objectives are basically to discuss the guideline development process a little bit. This might be of interest to people, and then discuss the evidence and some of the recommendations behind the guidelines. I might highlight a few for each of those recommendations, highlight a few of the articles that might sort of maybe there's something unique about them that sort of drove the decision. So I've provided a little bit of more detail on those aspects. Also, there have been other articles that have come out that might be of interest. And I know Micah has been involved in an ongoing clinical trial, and so Micah is going to jump in when we reach that part and give us some good insights about that too. So that would be interesting to hear. Okay, so the panel was, it was a multidisciplinary panel and had physicians, a few pharmacists, nurse practitioner, and respiratory therapist, and so mostly it was a panel was comprised of physicians, and we started off. So the guideline process really starts off with this brainstorming, and so it's a brainstorming where everyone comes up with the most important questions that we should be asking, and it's not hard and fast. There's a little bit of an art to this, and so everyone sort of had their own sort of questions and of what were important. We put it all together, and it had they're in the PICO format. So if you're not familiar with that, it's a patient intervention, so the population intervention, comparison, and outcome. So drug A, RSI patients, rocuronium versus succinylcholine, outcome, first pass success. So all of the questions had to be sort of in that format. And the end of the day, I mean, we came up with 35 questions, and then went through this voting process. It's a Delphi, voting process online, where you rank the importance of the questions independently, and so it's kind of, you fill out a survey, and then the top questions sort of, the top questions emerge of what we want to focus on. The one thing I didn't really realize was that SCCM actually a priori said that we can only do, so many questions, because each one of them is like a systematic review. So SCCM said we can do 10 questions. That's all we can do. And as you know, SCCM, the guideline process has now changed to become more rapid with fewer questions so almost like living guidelines in a way where it doesn't take, 5 years to get another guideline. And so it was 10 questions that finally emerged. Each of them was a systematic review, so which means that we had a librarian who did a full-on search on multiple databases to identify the relevant articles. And once they're those identified, they're screened, and finally we go through the grade process. So what does that entail? So basically, for each of the questions, we rate the risk of bias. So most of these RSI studies, they're not blinded, and you can imagine why. And so there are issues with blinding. There are issues with whether they include all the patients that were randomized. So there was some risk of bias in a lot of the studies, and also the outcome assessments are not going to be blinded necessarily. There's inconsistency, which basically means that the relative risks were like all over the place. They weren't consistent. So one says it's good, one says it's bad, that kind of thing. Indirectness, sometimes what happens is it's not the right population. So for example, we may want to look at hypotensive patients who got etomidate, but the articles are just any patients, that kind of thing. And imprecision is where there's a huge variability. So that's where you have, it's driven by small sample sizes where the confidence intervals are very, very broad. So it's less confidence in it. And publication bias was really hard in my opinion. And this, the only way to do this is if you have a funnel plot. But because we couldn't really do that because the studies were so heterogeneous, and you basically have to look at other just small studies, industry funded, that kind of thing. So publication bias is different than risk of bias, by the way. And at the end, you come up with a recommendation, a suggestion, or a best practice statement. So if it's strong, then we would say something like we recommend. If it's conditional, then we suggest. And then best practice was generally when there was no articles that we could find, and so then we would make sort of a best practice. Okay, so this is just a snapshot, and let me just, I know there's a lot on this screen to digest, but let me just explain what this is. So on the left here are the questions, so questions 5 through 10, which I'm going to talk about today. And on the right are the outcomes. The population was the same, so basically critically ill patients who are undergoing RSI generally. And so the first one, first question 5, was the use of intubation vasopressors versus fluids. And you can imagine the outcome for that would be something like hypotension, whether there was some kind of cardiovascular collapse. That was the outcome. And spoiler alert, there was insufficient evidence for that one, but I'll go through a little bit more detail. Induction agent versus no induction agent. On face value, when you think about this question, you're thinking, wow, can you really not use an induction agent? I mean, but I'll explain why that question came up. And so the outcome for that was really, if you don't use an induction agent, then you'll have people who are, have this awareness under neuromuscular blockade, and that's awful. So that was the outcome. Etomidate versus other. Here, there was discussion about this, and when we went from those 35 questions to the 10 questions, maybe we were a little greedy in a way, because the original question was etomidate versus ketamine, and Micah's doing a trial on this, but we wanted to somehow have the guidelines discuss the other options too, like propofol or midazolam, and so it was etomidate versus other, but in reality we did look at the etomidate versus ketamine question, and the outcome for that was mortality, and there's the issue with adrenal suppression and whatnot, so hypotension, vasopressor use. Etomidate plus or minus corticosteroid, same thing, that people have, because if someone's adrenal insufficiency, maybe you give them a corticosteroid with it. Neuromuscular blockade versus no neuromuscular blockade, that was another question of importance, and this gets to the cannot intubate, cannot ventilate scenario, and could you not use neuromuscular blockade in some patients. And then rocuronium versus succinylcholine were the ones, and the outcome for that was, first pass success was the major thing, adverse events. All right, so that sort of goes out. This is a snapshot of what I'm going to talk about, and then I'll go through a little bit more detail about it. Okay, so the first question was, in critically ill hypotensive patients undergoing RSI, was there a difference between these vasopressors versus fluid? So just to draw your attention, the question was really about hypotensive adults, because we assume that if you're hypotensive, then you'd be doing something, giving them a vasopressor or fluid. But as you know, there's not a lot. The trials really, because it's a subset of a broader population, it's very difficult to do trials, and that's why at the end of the day, there were no studies comparing vasopressors to fluids in hypotensive patients, and we basically had to say that there's insufficient evidence to make a recommendation. And I know that sometimes that's disappointing even for us, and I know that the audience never wants to read this in a guideline, but we came to the thing that there's not enough evidence to go positive or negative on this. We were also concerned, there was some concern from some panel members about risk for medication errors with using push dose vasopressors and how they're drawn up. Now I know in America there's these pre-filled syringes of phenylephrine and whatnot. Now in Australia we don't have these routinely, so a lot of the times they're drawn up. We have a drug called metaraminol, which I know is not in the US, and that's sort of our go-to. It's like a phenylephrine equivalent, but it's in these vials, has to be drawn up, and you could make errors with the wrong concentration. So it really depends on where you are in the world and what you're doing. So there were evidence gaps. I'd say the entire thing is sort of an evidence gap. There was no sort of comparison, but in addition to that, which vasopressor to use, the dose, the bolus, or can you use a continuous infusion? None of these were. This would be good for future studies. Maybe it's wishful thinking, but of looking at subpopulations. But those people who are particularly at risk, maybe they would benefit from one versus the other. Would be good. I don't think that would be the first comparison. Maybe subsequent ones. Okay, so just to go through, there was another. So there was this study, this cohort study. It's worth sort of pointing out. It wasn't a it was this international cohort study across many countries. I think 30 countries or more, but involved Europe, Canada, the US, lots of places. And they looked at people who got vasopressors and the risk for cardiovascular collapse. And they did some good analyses. They did inverse probability of treatment weight, which is a good way of adjusting for confounding. And they found that there was no difference. Now, there's always bias. Usually when you think of bias, those people who get a vasopressor are probably the ones who are more severely ill and more likely to have a poor outcome. So you would have expected to find that it in the other direction. So, but basically they did not in this study. And when you look at the figure on the right, what that's the change in the systolic blood pressure. And the dark and the light boxes there just tell you those who got vasopressors and those who did not. And you can see across the board based on the baseline, although those who had a higher baseline had a greater decrease, and that's just regression to the mean in a way. But you can see that both of the box plots were pretty much the same across the baseline. It's also good to look at the definitions of what is cardiovascular collapse and instability. So either it's just a very transient decrease in blood pressure, but quite a big drop, systolic less than 65, or a little bit more sustained over 30 minutes, but then it's less than 90. New vasopressor need or increasing the dose of the vasopressor, or people getting a fluid bolus or cardiac arrest. And what's interesting is that what I found that in the study, a lot of people actually already were on vasopressors before they were intubated. So I don't know what sense that makes. There was a pragmatic randomized controlled trial. It wasn't a huge trial, but and the reason is they stopped it early. So this was a good journal, Lancet Respiratory Medicine, where so it doesn't. So again, when you talk about indirectness, this wasn't a fluid versus vasopressor comparison. This was a fluid versus no fluid comparison, and they included people who weren't necessarily hypotensive. They were just sort of optimizing them before, and the study was stopped early for futility. And you can see the plot here in terms of who got a vasopressor or who had blood pressure decreases. It was pretty much equivalent between the groups. Now, one interesting thing about this was those patients who were receiving positive pressure ventilation, the subgroup benefited from fluids. So maybe some people, and you would think physiologically, okay, they have increased intrathoracic pressure, decreased venous return, maybe they should get some fluids, but that needs to be evaluated in a future study. Okay, so the next question 6 was induction agent versus none, and so this question came up is that first of all, you're not going to, avoid an induction agent in people unless you really need to avoid it. So so the population was really those who already had hemodynamic instability, and second, they had to have a depressed level of consciousness. I mean, these are people who are already sort of unconscious. I mean, you wouldn't not give someone an induction agent if they're conscious. And so we wanted to know in the subset, would sedative hypnotic um, versus none, would it have an effect on cardiovascular collapse or awareness during intubation? Now, there were no comparative studies evaluating this. I'm not surprised. We're looking at awareness. I mean, it's such a difficult study to do. You would have to interview people afterwards, and that too, you'll only be able to interview the survivors. And we also considered that, there's this potential for harm without giving people an induction agent. Would you really want to do that? And, would people have awareness afterwards due to PTSD, that kind of thing? So what if there was a future trial? I mean, how would you do this? That's the question. I mean, there are ethical concerns of withholding an induction agent. So I have doubts that this will ever be done. But it's possible that you could maybe look at lower doses, and that was one of the things that the panel said. Maybe comparing a low versus a high dose, maybe that's ethical, maybe that's possible. But at the end of the day, we said that we advise administering a sedative hypnotic agent. So you can see that this was a best practice statement. So you can see the difference between question 5 and 6 is, even 5 did not have any evidence, but we said there's no insufficient evidence. But question 6, because of the grade format where you're going through this evidence decision, you're looking at the benefits, harms, values, preferences. You're looking at costs, feasibility, and all of these things. And you can make a practice statement based on what the panel thinks, but it's based on opinion. This is an interesting study. It's mentioned in the guidelines, but this was a prospective observational study. It's kind of a unique study because they actually interviewed people who had survived and had neurological capabilities afterwards. And they looked at one of the questions in the Bryce questionnaire, which essentially asked, did you remember, recollect anything after intubation? And they also had to have obviously received a neuromuscular blocker. And you can see that 10 patients did have some kind of awareness under paralysis. So it's kind of concerning. It's a small percent, but still interesting. And the induction 5 and 5 etomidate ketamine, but actually the majority also had received long-acting neuromuscular blockade. So that's part of another question which I'll discuss in a little bit. But you can see, it says 383, but they really started off with 3 times that amount, close to 900 patients, because so many of them either they're lost to follow because of death or neurological injury, they couldn't be interviewed. Okay, question 7 was about the induction agent selection. And so you can see this was, is there a difference between etomidate and other agents? So originally the question was, etomidate versus ketamine, but then, the panel decided that we should sort of broaden it a bit so that we could talk about the others. And so it was almost like you could make, based on the the guideline folks, experts, they said, you could do that. And so because we were restricted to 10 questions. And does it have an effect on hypotension, vasopressor use? Because everybody knows at this point with etomidate, there's that concern about adrenal insufficiency. It inhibits 11 beta hydroxylase, and although there's not been any difference in clinical outcomes shown so far, he said, well, maybe there's an issue in terms of vasopressor use and mortality. And so ketamine, ketamine is interesting because it's also hemodynamically, a pretty good agent. But if in some people who have the catecholamine stores are depleted, maybe it can cause some hypotension. And so that was the sort of the reason behind this question. And there were some RCTs in this for this question, but there was no significant difference generally between mortality between any of these agents. And etomidate, and even ketamine had good hemodynamic profile, and so there was really no difference per se. I think in my mind it wasn't a fair thing to group like propofol with these, because propofol is clearly, and midazolam, I mean, these are a little bit different and with a greater drop in blood pressure. So I think that's just an ongoing question that we need to look at. The evidence gap is certain patients are already on steroids, maybe they have their risk for HPA suppression, and then in some patients with higher severity of illness, which there's these subgroups that have been shown to be have a heterogeneous effect. So we suggested that there was no difference between etomidate and the other induction agents, but in the text, if you look at it closely, we did discuss some of the issues related to grouping of propofol, for example, would be quite different, and midazolam versus ketamine when we look at this question. I like, this was a recent article, came out earlier this year, but so it came out after the guidelines, so I thought I'd bring it up. But what they did was a Bayesian meta-analysis, and I thought it's interesting now because a lot of the people are getting away in a way from this dichotomous frequentist methodology where we just have this 0.05 p-value threshold, either it's good or it's not good kind of p-value. So this a Bayesian analysis giving you a probability that's more on a continuous scale, looking at a posterior probability, gives you more information. And what was interesting is in this Bayesian meta-analysis, they looked at, they had 7 RCTs and 1 propensity match study. And they saw that there was a 80-something% probability of a survival benefit with ketamine. I don't know what to make of this. I mean, it's more than 50%, but it's 83%. So overall, they said that there's a moderate probability that maybe it's better than etomidate. So that's interesting. But when they took that 1 propensity score, the propensity match study, and they just looked at the RCTs, it dropped it to about 60%. So take it with a little bit of a grain of salt there in terms of this. So obviously, this would be a good for an ongoing trial, and this is where Micah comes in. And Micah, you want to jump in? And so this is the Vanderbilt group, very impressive, who are doing a lot of these clinical trials. And I know Micah and your institution is involved in this one that's comparing ketamine and etomidate. So maybe I'll let you jump in and talk about these.
Sure. So, there have been a number of trials, and it's, this group are really interested in doing a lot of sort of peri-intubation airway management things. For instance, you had mentioned PREPARE specifically. We also ran the PREPARE 2 trial, which had over 1,000 patients in it, which again, also did not show significant difference in empirically fluid resuscitating patients. And one difficulty with those trials is that you have to exclude ethically patients who are at higher risk, right, where clinicians feel like they're likely to benefit. And so that increases your risk of not finding what would be, that doesn't mean that giving patients fluids or giving patients vasopressors when they're at high risk is not helpful, right, just because there's no clear benefit. But this is another trial that we're doing, which is targeting a similar number of patients in enrollment in a prospective randomized controlled fashion, specifically looking at etomidate versus ketamine for induction of anesthesia for RSI. And our target enrollment is almost as many patients as that entire many different RCTs meta-analysis had with the, and I'm a very simple clinician, simple-minded, many people would even call me. So the Bayesian meta-analyses, while they really make sense, I like the KISS approach, and asking a simple question and then putting it into real practice that can be broadly applied to large numbers of people with, we've got a target of over 2,300 patients here. We're almost halfway done with our full enrollment, right? It's a very simple question and a very simple control. You're either randomized to etomidate or you're randomized to ketamine with a 30-day mortality marker, right, as your primary outcome. And if the Bayesian, the really smart Bayesian guys are correct, then we will see a difference. If not, well, we'll know we'll have some more information.
All right, thanks a lot, Micah. Great to have your insights on this, and so that'll answer a question once and for all, maybe. And what's interesting, Micah, is that etomidate is not available in Australia. So although the rest in the US, there have this debate of ketamine versus etomidate, we're already pretty much all ketamine. I mean, so like you wouldn't even have any equipoise here, and so it's interesting. It's just not marketed in Australia, and I guess our outcomes are pretty good.
Yeah, I didn't know that. Here in the United States, the majority of intubations are performed with etomidate, not ketamine.
Yeah, I know that. I know how interesting that is.
Worldwide difference is very interesting.
Yeah, so I mean, I think we're pretty much 90%, probably 90%. I think would probably be ketamine, rocuronium. That's very, and so yeah, at least at my institution, I know this. Right. Okay, so the next questions are building on that etomidate question was etomidate and corticosteroid use. So maybe, if you're worried about etomidate and adrenal insufficiency, then what about co-administration of corticosteroids, and would that be beneficial with respect to mortality, vasopressor use, and all of these things? You can probably guess what the result was if you haven't read the guidelines, but basically there was no difference in mortality or multiple organ dysfunction syndrome based on some of these trials that had been done, and there was some great heterogeneity too in terms of the doses used. For example, one study would use 200 milligrams as a continuous infusion after intubation, as a continuous infusion over 42 hours. They had 42 hours, versus another one had 200 milligrams continuous infusion over 24 hours. And then another had these intermittent boluses, 50 milligrams every 6 hours, and then titrated, and then, the standard sort of sepsis regimens. And so great differences between the different studies. Overall, we said there was a low certainty of evidence. And then there was, we mentioned this in the guidelines. We had mentioned certain subpopulations like sepsis with cirrhosis because they have a high incidence of adrenal insufficiency. But at the end of the day, we said that we suggest against administering corticosteroids. So remember, this was a conditional recommendation, so it suggests. But because of the grade methodology, you're looking at the evidence in terms of certainty, but you're also looking at the implications of recommending something, and the extent of the benefit, the extent of the risks, the impact on the healthcare system in terms of costs, and are we going to say, should we be silent on this issue, or should we say that we suggest against doing it at this time? And so we came down on, we suggest against administering corticosteroids, and I think that was the right decision. But you can see how you can have the same levels of evidence, but then based on the situation, the panel had a lot of discussion, a lot of debate about where you finally come down on the issue. So I think that's quite interesting. And although we mentioned this in the guidelines, and I thought it wasn't really that apparent, like even though we mentioned that maybe there should be the subgroup of cirrhotic patients with sepsis, when you finally actually pull up that reference that's in there and you look at it, it's a really small study where it was this nested cohort within an RCT with really small sample sizes, where they they sub-stratify these people who got etomidate into those who got hydrocortisone or placebo, and they seem to have like this improvement in ventilator-free days, but I don't know if this means anything because of the small sample size. It just means probably nothing. So very difficult to do a study like this. If you were to do a randomized controlled trial of etomidate versus something else, can you imagine, Micah, if you're trying to just enroll people who had just cirrhosis? I mean, so it would be impossible. It would be so difficult. You need a worldwide study. So question 9, so in critically ill patients, is there a difference between giving an NMBA versus a sedative hypnotic agent alone? So this is that cannot intubate, cannot ventilate scenario. And maybe there are certain patients, so maybe you don't use a neuromuscular blocking agent, maybe intubation technique is become so good, people are using new devices, who knows? So we looked into this question. It seemed to be something of interest to the panel. And so what we found is that basically when you use a neuromuscular blocking agent, the first pass success rate, so that's the first attempt of putting in an endotracheal tube, was considerably higher when using a neuromuscular blocking agent. So although if you look at the designs, they're all observational. And here you look at, although it's observational, the effect size in terms of the differences were quite stark in a way. How people measured safety was also quite different between the different studies. So it was a very low certainty of evidence because these were all observational studies, okay? But at the end, if you think about it, we still came up with a recommend. So it was a strong recommendation, but it was based on a low quality of evidence. And I think the thing that drove this was that just the differences in the observational studies, and some of them pretty good observational studies, were quite big between success rates. So I think at the end of the day, we said that this should be a strong recommendation. And so one of them, this was done by Jared Mosier, and he was one of the people on the panel too. But he looked at this. It was an observational study, a prospective registry that they have at the University of Arizona, and basically, first attempt success, the odds of success was a lot higher with those who used when a neuromuscular blocking agent was used. All right, and so this is the last question in the guidelines, which is in those patients undergoing RSI, what about rock versus sucks? The eternal question that people keep asking for a long time, and what about mortality, first pass success? Risk of awareness is another issue that has come up because of a long-acting neuromuscular blocking agent. And so there was no difference in the studies. And I'll talk about this one recent. You're probably aware of the recent French study that was a comparison, a non-inferiority. I'll go over that. But there was no difference between the two. There was one small retrospective study where there was increased risk of mortality in a subgroup of people who had a high severity of traumatic brain injury. So it's hypothesis generating, but a low certainty of evidence. And it's based on some of the animal data. So what about, so maybe there could be a trial in people with traumatic brain injury, optimal dose, what's the optimal dose, and then post-intubation outcomes. So I think one thing that was unique about the guidelines is that, if you look at previous Cochrane reviews, the outcomes been first pass success. And no one's really been focused on what happens, when first pass success is going to becomes really high, then you start thinking about other things, like what happens after intubation. And that's been one issue of this, paralysis without sedation and giving people sedatives and analgesics, which is good, that was discussed as part of the guidelines. So we suggested administering either one for RSI when there's no known contraindication to succinylcholine. And as I said, what's interesting is that out here, at least our practice, what I see is basically it's 90% rocuronium now anyway. It's interesting. So this was the French study. This was done in the pre-hospital environment, so it may not be, so how does that, and they had these physicians who were doing the intubation, so I'm not sure how it would apply to Australia or even to the United States in a way. They didn't, the other thing is, Micah talked about using video laryngoscopy, and that has superior outcomes. And so in this, it was all direct DL. So that could be a factor too. And it was a non-inferiority study. But basically what happened was it was inconclusive. The study was inconclusive. So they couldn't reject non-inferiority. So they couldn't say that it's non-inferior. So you can't say it's superior. You can't say it's non-inferior. And that's because you look at that line, on the right, it exceeds that 7% margin, non-inferiority margin. And so basically the study was inconclusive in a way. So you can't, so it's kind of weird. This was the one retrospective study. This was the one we did. But look, I'll be the first to tell you that this is not high level of evidence, but we did find a high high risk of mortality in these people with a high severity of traumatic brain injury who got succinylcholine. And this was because of some, the question came up because of some animal studies where they showed the increase in ICP when you got succinylcholine. But I think that I wouldn't go by this. It would need a big randomized trial to really answer that question. So here's the issue that I was talking about is when you give succinylcholine, and Micah said that etomidate is probably the induction agent used mostly. Both of them wear off at the same time, and that's the time when a patient would start moving if they're intubated, and you'd give them some additional sedation, some propofol, to keep them sedated. But if you give them etomidate and rocuronium, then you have this mismatch in the pharmacodynamics, right? So there's a longer duration of action of rocuronium. So now, right in that 5 to 10 minute mark, people have the appearance of sedation. And in a hectic emergency department, you can imagine that sometimes that may be missed. Now, to give people extra additional sedation. And so that's a concerning issue. And I'm glad it was discussed in the guidelines. But there's this pattern that's been emerging, and a lot of these retrospective studies that have come up, I've just listed them for you. But when you give someone rocuronium versus succinylcholine, they've shown that those people who got rocuronium tend to get less sedatives. The time to sedation is less. The dosing of the sedatives and the analgesic is less. And there's must be like 10 studies now on this. And also, what was interesting, there's one study where the pharmacists, there are more than one study, but if the pharmacist had an effect on giving someone timely post-intubation sedation if they were part of the resuscitation team. So that's sort of a summary of the recommendations. We've discussed all of these, and happy to answer any questions. Thank you very much.
All right, thank you both, Dr. Whitson and Dr. Pantawala, for a great presentation. It was very educational. It was very interesting to hear two different sides, the guideline summary and clinical experience from Dr. Whitson, and also some of the behind-the-scene decision-making process and literature summary from Dr. Pantawala. So thank you both for amazing presentation. And at this time, I would like to open up the floor for any questions from the audience. Feel free to utilize the chat box or raise your hand virtually, and I can unmute you. Thank you. So I guess while we're waiting for any questions, I saw your comment, Dr. Whitson, on the chat box that your study on 1,000 patients regarding the fluid resuscitation versus no fluid. So could you maybe expand on that a little bit?
I touched on it briefly when I had spoken up about RSI and the difficulty with any kind of studies is understanding the generalizability to the patient population you're actually going to be treating. And so in order for us to run these types of trials, in order for any vasopressor study, for instance, or IV fluid study to be run, you have to exclude patients that may cause a moral quandary for the treating team. And so anyone where they look at the patient and they say, oh, that person looks sick. Ooh, their blood pressure is 100. They may tank. I feel very uncomfortable not getting their blood pressure up to, say, 120 systolic. Those patients have to ethically be excluded from studies. And so you end up, in some ways, selecting for patients that may be less likely to benefit from the intervention that you are actually testing for. And so when you find a no difference study like that, that doesn't mean that intervention is not useful for all comers. It just means that you don't know that empiric utilization of these medications or empiric utilization of IV fluids for all comers when you can test them is going to improve outcomes for all comers. So I still routinely give empiric vasopressors to patients, or vasopressor, maybe not empiric, withholding vasopressors from hypotensive patients when you're about to intubate them would be considered not within the standard of care. And so we still do that, even though there's no, quote, strong evidence that this benefits patients, right?
Do you have a preference? I'm sorry, go ahead.
Oh, go ahead.
I was just going to ask, do you have a preference between like a push dose phenylephrine or norepinephrine that Dr. Pantawala was talking about in your clinical practice?
In my clinical practice, the majority of patients who are, quote, high risk that I would empirically start on medications are those who have septic shock. And our first line agents are agent is norepinephrine generally. And so again, I've expressed I'm a simple man. And so why give so many different medications? I can't understand pharmacokinetics or physiology. So start them on norepinephrine, put them on a drip, get their blood pressure up, because you know that they're going to be on it anyway for the septic shock. And then once you have the appropriate, what you would consider probably safe hemodynamics, then proceed with intubation whenever that's possible. Now, there are some times, of course, when you don't anticipate precipitating hypotension because the blood pressure is 138 systolic. But as soon as you hit those sedatives, they crash. And in that situation, utilizing push dose pressors with either phenylephrine or sometimes epinephrine, depending on whatever you have available, is generally more rapid and would result in maintaining higher blood pressures more rapidly than getting out a drip of levo and putting it on and then trying to start it and getting to drip in slowly. You're just gonna anxiously watch the map for a much longer period of time if you use that route.
Yeah, I was just gonna say that. So I liked your point about who you enroll in a trial, and so if you, and this is my experience from here being on the clinical trials committee, is that there has to be clinical equipoise that between the two comparators. So if the team already knows that this person is going to benefit from fluids or from a vasopressor and has made that decision, then they couldn't be enrolled in a trial because it would be against what the team thought was best for them. So that's, I think, one issue to think about in trials and in future trials. Because a lot of these things, like in emergency medicine, critical care, where consent, depending on how it's done, I mean, because consent there's a waiver of consent, and you have surrogate consent if available after the fact. You have to really be so the intervention, for example, in our from an ethical perspective, when you're choosing an intervention, there has to be this hint from previous studies that the intervention that you're going to test has some benefit. So, for example, like I was thinking, would we ever be able to do a study comparing propofol as a comparator? I don't think we would be able to, unless there was a population where you could say that it really benefits the patient beyond the standard.
Yeah, there's a possibility for niche studies here, which wouldn't be addressed, for instance, like in our RSI trial. So as an example, with propofol, there will be very, very few people enrolled in our RSI trial, even of the 2,000+ who have, who are being intubated for status epilepticus, for instance.
Yeah.
Because the overwhelming practice for us is patients being intubated for status epilepticus will be sedated with propofol specifically. And so that's a very, very, very small subset of a population, and so it clearly this study would not be generalizable to that sort of thing. And then you could do a study where you randomize patients to propofol versus other specifically for status epilepticus. But you touched on it earlier, when you start talking about very small populations and much more uncommon disease, while cirrhosis is nowhere near as uncommon as requiring intubation for status. Just the feasibility of performance of a massive clinical trial in very small subsets of patient populations is impossible to overcome, right? It's a challenge to tease out some smaller nuances of things, but I think when you're the proposed or theoretical beauty of the multi-center, the multi-study Bayesian meta-analyses is to be able to try to find more broad strokes and more generalizable questions in larger patient populations. But I think there are also clear pragmatic ways in which you can ask very specific questions and apply it in a very broad situation. Now, what we do here in the United States with ketamine versus etomidate may not be as generalizable to the Australian population, right? But when you allow for providers to have simple pragmatic trials where they hold everything else the same and the only intervention is this drug versus that drug, right? Then I think it also still gets you pretty clean information that you can use to also, translate into future clinical practice.
Thank you both for your answers. There are some audience questions on the chat box. I'm going to read them off. With the increased use of long-acting paralytics, what is your approach to minimizing awake paralysis? Bolus doses with a low dose of infusion or infusion alone?
I'm not sure if Sid wants to weigh in first. I can certainly talk about my clinical practice.
I think how it depends on, I think the bolus doses it depends on how things are structured in terms of different countries and institutions and the protocols that they have. I mean, I think it's a good idea to start that infusion as soon as possible. It may be that there's a delay in doing that, in starting an infusion. So I'm definitely a proponent of giving a bolus if the hemodynamics can if the patient's stable, can get it. So that's also a good idea. But yeah, if you bolus, depends on what you're bolusing, right? I mean, if you do bolusing some propofol, I mean, right after intubation, and then you have hypotension, that would be a problem. So yeah, if you can get that infusion started quick, that would be good. But sometimes if you're in a situation where you can't, then maybe a bolus of something might be okay, even if it has to be like a benzodiazepine.
Yeah, I agree 100%. And thoughts about the pharmacokinetics of the specific drugs are very important because the half-life and the duration of clinical action for rocuronium is going to be longer than ketamine and longer than etomidate, and certainly much longer than propofol, right? And so using a short-acting benzodiazepine, of course, short being relative, midazolam has duration clinical activity, Versed, I guess if you're in the US, has a duration clinical action that's gonna be closer to what you would see with rocuronium. So my routine clinical approach is, when hemodynamics allow, as you said, I always give bolus of midazolam immediately post intubation. Once we've finished the intubation and we've assessed the hemodynamics and we have stability and safety. And then I, after that, put in orders for the beginnings of continuous sedation. Our continuous sedatives are usually, in our institution, and most institutions that I've been in, are usually fentanyl and propofol. I always start fentanyl in a drip form for patients who are intubated. And I usually will start low doses of propofol unless, again, I'm very worried about hemodynamics.
Okay, great. Thank you both. There is another question from the audience. What is your choice of induction agent for intubation for renal failure patients?
I'm glad to answer. My choices in my current clinical practice is to enroll them in our trial as quickly as possible. And the trial tells me which one I have to use, and ketamine versus etomidate. I think the usual practice here would probably, I mean, without any strong evidence, would in the United States favor etomidate. I don't know of any reason to not use ketamine in a patient when, with risk for renal failure, when you're talking about sedation.
Yeah, I mean, we don't even have that option. I mean, so we pretty much all ketamine for the most part in most patients, and yeah, it seems to be that that's sort of what we do.
Now, there are some few centers, and I've been in one, that will actually use propofol as primary induction agent. In sick patients undergoing RSI, where you have a much higher likelihood of peri-induction hypotension, cardiac collapse, and complications, you cannot give, well, you can, but should not give large bolus doses of propofol when that's utilized. And there are some papers that describing this having been utilized successfully without increased complications. It's always given in small micro boluses, 20 or 30 milligrams at a time, until appropriate sedation is achieved. And then once that sedation is achieved, that can be followed by a paralytic, or in some cases, these institutions choose not to use a paralytic. Again, there's a large amount of evidence-free zone in this.
Perfect. Thank you for your answers. And I do not see any more questions in the chat box at this time. Do you, Dr. Whitson and Dr. Pantawala, have any closing remarks?
I hope the the information provided was behind the scenes, gave you a little bit more information than the reading the guidelines, and thanks for having me.
I'll echo that. Hopefully this was helpful, and thank you for the invitation.
Thank you both for joining, and thank you everyone for listening in today. This will be the end of our lecture session. We'll see you at the next lecture. Thank you so much.
Thank you. Thanks.